A very good evening to all. Thank you for joining us for the sixth of our series of case presentations. Today we have with us our presenter, Dr. Janani, who is a final year postgraduate from the Institute of Child Health, Madras Medical College in Chennai. And our examiners for today are Professor Prakash Agarwal, HOD and Professor in Sri Ramachandra Institute in Chennai, as well as Professor Rakesh Joshi, HOD of BJMC Ahmedabad. Both are very seasoned and experienced examiners, and I look forward to learning with all of you today. Thank you. Dr. Janani, I think you can start.
Good evening, sir. I'm Dr. Janani, final year postgraduate from Madras Medical College.
Good evening.
I would like to. Yes.
Yeah, please start.
Yes, sir. I'm going to present about a 6-month-old child who came with chief complaints of anteriorly detected abnormal renal findings brought by his mother from Kanjipuram district, whose reliability was fair. History of presenting illness: child is a known case of anteriorly detected right hydronephrosis brought for postnatal follow-up. Stream is good. No complaints of mass per abdomen, no complaints of excessive cry while passing urine, no complaints of increased frequency or dribbling, no complaints of fever, loose stools, vomiting, no complaints of hematuria or pyuria, no history of any feed intolerance. Child is thriving well. Antenatal history: it is a booked and immunized pregnancy. Antenatal scans done at 21 weeks showed right renal abnormality as said by the mother. Perinatal history: it's a firstborn term, born via naturalis, birth weight 2.8 kg, no NICU admission, passed urine with good stream at 24 hours, child being discharged thereafter elsewhere, and is not probably followed up postnatally. So marital history: it's a non-consanguineous marriage, no maternal comorbidities, and
एकदम धीमे आवाज है.
Sir, I cannot understand, sir. Sorry.
Oh. Sorry. You please continue.
Okay, sir. The mother is a preemie. Treatment history: no other comorbidities, and child is not admitted elsewhere for any procedures, no previous surgery. Immunization and developmental history: child is immunized up to date and child attained milestones as per age. So summarizing my history, it is it's a 6-month-old child who is having an antenatally detected abnormality of right renal with no negative history, with no positive history of any UTI, and the stream is good with no significant past or family history. Shall I proceed with examination?
So no, just I wanted to ask. I mean, you are just describing it is like renal anomalies. So the antenatal scan, even gynecologists, they didn't explain what is that, whether it is a hydronephrosis or something like. What is the issue, in antenatal scan? Because all your history goes based on that only.
Yes,
That patient is having some abnormal renal findings during antenatal scan, and there is nothing. It just a present for a postnatal follow-up. So how we are going to ask all these negative histories because you don't know about what is renal anomalies they are explaining. They either say it is something like ballooning of that, or they say something like, yes, there is a swelling in the kidney, or they say something there is a oligohydramnios or polyhydramnios. What sort of these things they are actually talking about? So based on that, definitely your negative history will be very important.
Sure. So the antenatal scans, after the presentation I have put, sir, but the antenatal scans is showing in ballooning of the right kidney, and child is having, mother is having normal AFI index in the pregnancy.
No, not about that, because when you're taking history, you don't know about that scan,
Yes, sir.
You don't have that
Yes, sir.
availability of those reports. You
Yes,
just have to ask the mother or what basic information they have about the antenatal anomalies. So in general, gynecologist or whosoever, maybe pediatric surgeon, they explain that there is a ballooning of the kidney or there is some swelling in the kidney. And there are different reasons for that. See, based on that, your negative history matters. Why there is a ballooning, whether it is very, many times it is very difficult to detect hydronephrosis with hydroureter.
Yes,
Even you cannot disclose the sex, right? So you have multiple questions in your mind when you say ballooning of the kidney. What is it actually? It's a lower tract obstruction, it is reflux, it is these, it is PUJ. So all sort of these things will come into your mind, and then based on that, you have to ask the negative history. So that's what I was just wondering, that what sort of things they have informed to the mother or a family.
So they have informed it is an renal size is increased and it is ballooned. They have to follow up after. It is not an emergency. They can follow up after 1 week with an ultrasound. But mother has lost follow up.
So when they say nothing is serious and you just have to follow, what thoughts comes into your mind?
So
What is, I mean, what do you mean by that?
Sir, it should probably be without any ureteral dilatation or bilateral. They have ruled out, if it's not an emergency, then they have ruled out PUV. Otherwise, the bladder wall thickness is not mentioned, and they have not asked for a tertiary care delivery. And so probably it should be an a right renal
No,
hydronephrosis.
don't jump into that straight away, because this information that everything is fine except ballooning or swelling of the kidney, what other very important findings they should have told? Don't worry, this is also okay. So you just keep follow. When you are talking about antenatal renal issues,
Yes, sir.
what things comes into your minds? You said rightly that bladder, okay.
Yes,
You
sir.
said kidney, okay. Difficult to
Sir,
detect about ureter, okay. What else? Which is a very gross finding.
sir, any associated any adrenal mass or the liver mass we have to.
No. We are just, kidney and around kidney. Forget about other association. What is
Okay.
very important when you are talking about antenatal detection of some renal anomaly, what comes into your mind? You are thinking about the
The
waves of
parental
hydronephrosis or swelling. In terms of parents' history, it is definitely a swelling of the kidney,
yes, sir.
right? So what else? What is other surroundings things you are also worried about?
What it leads to? What is the urination in the fetus leads
Yes,
to?
yes,
Sir, AFI, sir.
Tell
yes,
properly. AFI, if you start using
Amniotic fluid
small,
index, sir. Amniotic
yes.
fluid index, sir.
Yes. So you have to ask, or you have to, take that history. It
Yes,
is
sir.
very important, because ultimately the doctor will say that everything is fine. Fluid is
and one
absolutely
more thing,
normal.
I agree with Dr. Joshi. See, you should not have the diagnosis in mind when you are presenting a case. Then the whole purpose is lost.
Yes, sir.
So whenever you are presenting a case, you should tell that there was a renal anomaly told to the patient. If you start from PUJO, then the whole purpose is lost. You know the diagnosis, or everything will be biased. The history will be biased. The presentation will be biased. So
Yes, sir.
everything will look forward to that only one diagnosis.
Okay,
So
sir.
in the exam also, you
Yeah.
remember, don't have that antenatal history finding in your questioning.
Yes, sir.
Or else you
When you
just
never
specify,
saw that.
click. Yes. Because if you say renal anomaly, then there are multiple things,
Yes, sir.
It is not only, you are not only can talk about hydronephrosis. You cannot, it is like a fix in your mind that yes, everything will go to that. Either it is a reflux, or it is a PUL, or it is a PUJ. No, it should not be like that. When you say renal anomaly, it has a multiple differential diagnosis antenatally. Could it be like multiple cyst? No, you have, because you don't know about that. The consultant will say about there is a swelling in the kidney, and you don't worry about that. Other than this, there is no other information you can find out from the parents unless you search the files, right? So you
Yes,
have a gross things in your mind that it could be this, it can be this, it can be this, and based on that you have to ask. So most of the important, very most important thing is, like as you rightly said, is AFI. You said it is everything is fine, and patient is, then it goes to the delivery time.
yes,
So once postnatal, you have to rule out all the things which can lead to all these renal anomalies,
yes, sir.
right? So I think that is very important for everybody, all the students, that when you are just describing that patient is absolutely normal and coming for the follow-up based on this history, you should have the negative history, the list of negative history. That is most important. Okay.
Sir, on examination, after getting consent from the parents, exposing the child completely, examined under the well-lit room, natural light. Child cry is good, alert, active, hydration is adequate. There is no pallor, icterus, cyanosis, clubbing, generalized lymphadenopathy or pedal edema. The AF is open and is level. The height and weight is on par with the age. Cardiovascular system examination, first and second heart sound heard. There is no murmurs. Respiratory system examination, bilateral is equal and adequate, no added sounds. Vitals examination, heart rate is 120 per minute measured in the right radial artery. Saturation is 98% in room air. Blood pressure is 90 per 60 millimeter of mercury
Why
in the
are
right.
you telling the vitals first and the cardiac system, respiratory system before that? Normally, all the systems we follow one after the other, no?
General examination followed by systemic.
Yes, you should do the general examination first, followed by the systematic examination.
Yes, true. Absolutely agree. So you cannot write CVS and RS in before the general examination, right?
Yes, sir.
So it is generally, then it comes to the specific systemic examination. When you are talking about abdomen, you can take about the abdominal examination first and then RS and CVS and CNS.
Okay, sir.
Okay. So that's fine. Okay.
And BP is 90/60 millimeter of mercury. Respiratory rate is 25 per minute. On inspection,
Wait.
Yes.
We will discuss, segment wise. We will not jump the whole case and then discuss. So come back once more slide. So what do you mean by this? I mean, this cry activity is everything is fine, but when you are telling there is no pelvic icterus, cyanosis, clubbing, generalized lymphadenopathy in such a small baby and pedal edema, AF is open, that is also a normal finding. So how you will correlate with these findings with your something renal anomalies detected antenatally? What do you mean by why you are expecting paler in such baby? It's a very healthy baby, looks very nice.
Yes, a child is looking healthy, sir, as a part of general examination, and also if in case any anemia, hematuria can cause an pallor, and also any since it's a right-sided mass, I can always look for any congenital neuroblastoma also, sir. In case if child is weak and pallor is present, I can also suspect that, sir. And icterus in case of any any liver mass. Since it's a right-sided mass, I haven't palpated. I just did a general examination, sir. Otherwise.
And cyanosis and clubbing, they are part of association.
As a part
Yes,
of general
associated.
assessment, sir.
So what I mean to say is whenever you are describing such findings, it is obviously it's a general finding, but
Yes, sir.
always correlate with your, what you are talking about. So there are some association with some general examination, like if you are thinking about neuroblastoma, then there are very important findings associated with general examination. Right, so you always should think about that. So that is very important when you say whatever positive or negative, but whether it is related with your findings or whether related with your diagnosis, it is very important. So you have to keep yourself open when you say no pallor. I mean, if you are thinking about hydronephrosis, why you are thinking about pallor? There is no hematuria. Maybe there may be some tribal bleeding or something like tribal trauma that can
Recurrent
lead to
UTI may
this,
also cause failure to thrive, chronic
right?
infection.
So
Yes,
yes, so that way you have to clubbing cyanosis. Clubbing, I mean, in such a small kid, it is not, it is not generally there. When you say general lymphadenopathy, then you have to look for the other generalized disorders, maybe some infections and this and that. So all these things, yes, but you should be, you should be aware about how to answer such question. Everyone will ask that when you say it. So don't make it like just a routine examination that we are going to tell this, but at least you have to correlate with your whatever case you are presenting. Forget about this, anything, whenever it is a lump in abdomen or any other case. So you just have to correlate that with the findings, right? So you said blood pressure. What next slide is blood pressure. What do you think? It is normal?
Yes, sir, it is normal for the child's age and height.
So what's the age of this patient?
It's a 6 months child, sir.
6 months child. So what's the formula for that?
The formula for
So how will you say that?
percentile,
You said normal. That means that you know how to count this.
sir, sir, the centile normal for the age as per the criteria, the IAP criteria only we have seen, sir.
So
Normal for the age. Centile, percentile, in which centile it
Does
has
it
come.
have any correlation to this case?
Sir, any gross hydronephrosis, which may cause, which is chronic, may cause an hypertension. Child can present with an hypertension in 10% of PUJ.
at this age,
At this
have you
stage,
ever seen a,
Will
I mean,
cause
5-month-old
hypertension.
or 6-month-old baby presented with hypertension?
no, sir, no.
No,
But
right?
in case
So,
if
I mean,
any
yes,
single kidney status, that in that case,
you have to, yeah, logically you have to answer because you will keep watch on blood pressure, right?
yes, sir.
Very, very rarely, unless it's it may be, but in that case, you have to see such think that scenario that it may be a single kidney or a highly damaged. So yes, so how
I
you are
cannot.
going to
Yes,
count that?
yes.
Okay.
Carry on.
Okay, sir. Sir, on inspection per abdomen, there is no distension. Umbilicus is in midline and inverted. No dilated veins, no scars or sinuses. Hernial orifice is free. All quadrants move equally with the respiration. On palpation, abdomen is soft, non-tender, no warmth. There was a palpable ovoid firm mass over the right lumbar region with smooth surface, well-defined margins above medial and the inferior margin. Laterally, it is merging with the flank, extending 2 cm below the costal margin till 2 cm above the anterior superior iliac chain, medially up to the umbilicus. Mass is ballotable, able to insinuate finger between the mass and the right costal margin. The mass is not moving with the respiration. Uh, the external genitalia appears to be normal and there is no cough impulse. On percussion, there is dull note over the mass. Renal angle, dull note is noted. There is no free fluid. On auscultation, normal bowel sounds heard and no bruit over the mass. Spine and cranium examination is normal.
So, I mean, what's your you just go ahead with the one more slide, then we will discuss.
Okay, sir. So, with summarizing my history, this is a 6-month-old child with an anteriorly detected right renal abnormality with no history of UTI and and the stream is good. Child is well preserved and with on palpatory finding, there is a right ovoid firm mass in the lumbar region whose margins are well defined and smooth surface and is moving with the not moving with the respiration and can insinuate finger. So probably it should be a right renal origin. And my first diagnosis, since the child is well preserved, I would like to give a differential diagnosis. First is right pelvic ureteric junction obstruction. Second is right multicystic kidney disease or right congenital vasoblastic nephromas.
So, can we go back to the inspection finding?
Yes, sir.
So, in your inspection, there is no distension, umbilicus is midline, no dilated veins, no scar, hernial is. What very important findings you are missing here? Very important.
Sir, any fullness,
So,
flanks full.
yes, when you are talking about renal mass,
Yes.
the first thing comes into your mind. Rest of the thing is normal because patient is presented normally without any significant symptoms based on an antenatal scan. But when you are talking about kidneys, when you are talking about renal mass, the first and foremost inspectory finding is fullness in the angle,
Yes.
right? So how will you examine that?
Sir, sir, we put the child in the lateral position, right lateral position, and can examine the flank, sir.
Then how will you compare with the opposite flank? How will you say that it is full? So you
Sir,
have to see both the flanks, right?
both the flanks, yes, sir.
So
On comparing both the flanks, we can see this right side will be more full in the flanks.
so then again it is not lateral. Then what else?
Sir,
So what's the landmark for renal angle fullness? Where you are actually supposed to see?
So in the posteriorly below the right costal, below the 12th rib and paraspinal muscle and the dullness noted between the triangle.
No dullness. We are just talking about inspection. No dullness.
Okay,
बहुत देर है अभी उसकी.
yes, sir. Between the lowest
It's a-
muscle muscle and the paraspinal
Yeah,
region.
right. So it's a fullness in the renal angle, and you cannot comment anything unless you have a vision of both the renal angles.
Yes, sir.
So if child is able to sit down, you can make child sit and observe from behind.
Yes, sir.
Or when such small baby who cannot sit, then you can make it prone and just examine both the flanks, and then only you can say yes, okay, one renal angle seems to be full. May not be all the time, it may not be necessary.
Yes, sir.
But yes, you have to mention this in your inspection. That is mandatory, whether it looks or not. That depends on the size of the mass also. Not every time you are getting fullness in the renal angle. But yes, at the same time, we have to look at it and we have to mention in our findings. That means the student knows the importance of that finding, right? So that is more important and more relevant. So that is very important thing. Next is the palpation, right? So you have mentioned is a soft, non-tender, non-warm, and a firm mass.
Yes,
I mean, do you expect PUGO is a firm mass?
so some tensely cystic structure may appear from yes, sir.
Then you have to differentiate it from the tumor. How will you differentiate it from the tumor?
So it's
When you say it is a tensely firm or a tense cystic is a firm, then you have some other findings associated with that.
So the surface is smooth, sir, and it's a well-defined margins is seen.
So can you compress it?
Sir, sorry, compressibility, sir, I cannot elicit that.
Not elicit, okay. You said it is a bimanually palpable.
The palatable mass, sir.
Okay, sorry, it's a palatable mass. So what is the difference between these two? Like when you are talking about renal mass, there are fixed clinical findings, where you can tell this is a renal mass based on just like if you think about ideals of renal mass, what are those things? One of the important is this one also, that is bimanually palpable. What do you mean by that?
So putting a finger under the in the flank.
Position of the patient. In which position you will elicitate this sign?
Sir, in the left lateral position, sir.
Why?
Sir, just in the sir, keeping the finger below the flank, we just make the child lateral, sir. But we can palpate in the supine position only, sir.
No, it is in the supine only.
So both the fingers are above the abdomen and below the flank. We can just palpate bimanually. When it's a larger renal mass, we can palpate bimanually.
So palatability means which finger will push and which palm or which fingers will feel it. What do you mean by palatability? That it is moving on a pedicle, right?
Yes, sir.
So from where you will tap and from where you will feel? Sir,
from posterior we have to tap, sir.
From back you will tap and then so it's in the supine position always, yes, right? Yes, it is not possible in a lateral. And when you say it's a bimanual palpable, it is a big mass. Okay. Yes. So that is one thing. What another important findings you are telling or missing here? What do you mean by this not moving with the respiration?
So it is not an peritoneal organ which is attached to liver. So liver or any peritoneal organ will move with the respiration, sir. So this should be a retroperitoneal mass. That is what I mean by not moving with the respiration.
But renal masses are slightly moving with the respiration. That is what is otherwise finding. But then how will you check this? One more important thing is how will you define that it is whether it is moving with the respiration or not?
Sir, while crying or
no. You cannot wait when you are doing examination or when you are giving exam. You cannot wait till child cry. You have to mention it in your paper.
Yes.
So how will you examine? Again, which position?
So with the position, so we can make the child in the prone or the lateral. It's falling forward. With that, we can examine, sir. With falling forward or what?
No. You have to check with the respiration.
with the
So how will
respiration.
you, anyway, describe the method of palpation of that? How will you define that this swelling is moving with the respiration? Like all the swelling attached with the diaphragm, like liver and spleen, they will
Yes,
move, right? So
yes,
how
sir.
will you define? Forget about this kidney, but ultimately you are talking about the abdominal mass in general. You have to rule out other things. So how will you define that this is not moving with the respiration?
Sir, so generally on so when keeping the child in supine position, we are sir, other liver or spleen will move with the respiration when child uh, sir, I
So
cannot.
what will happen with the respiration, with that swelling?
So with the inspiration it moves up, sir, and with expiration it comes down.
So that you have to keep your hands just at the edge of the swelling.
Yes,
And
sir.
then you have to feel it that yes, it is moving when baby is inspirating and expirating, inspirating and expirating. Then
Yes.
you are feeling it is touching your hand or a palm, and then it is going or moving away. Then you can say it is moving with a respiration or not, right?
Okay, sir. Okay, sir.
Okay. So
Can it
next,
happen that the swelling is appearing sometime and then disappearing sometime?
So, no, sir.
Can it
Sir, no.
happen in this case?
Sir, in a old, sir, you are asking in case of a PUJO, sir, or
Yes.
yes, sir. In PUJO, in older children, there is a condition called Diethel's crisis, which is in which the child can have mass with pain, and after urination, diuresis, the mass will disappear. It's called Diethel's crisis.
Okay, apart from PUJ, what else it can be? You have given 3 diagnoses. Can it be anything else, or you are just fixed with these 3 diagnoses?
Sir, sir, we can, if it is a mobile mass, then we can say any small bowel duplications is.
Compared to your finding, whatever your finding is,
Yes, sir.
it's a firm mass you are telling, you are able to insinuate your finger, and
Yes,
then
sir.
the shape and surrounding is quite smooth.
Yes, sir. It's a renal mass, sir. And child is well
No, don't be
preserved.
fixed with the idea of a renal mass. What
so
else it can be?
so when you say it is a smooth and firm, how will
Yes,
you
sir.
say it is a multicystic dysplastic kidney? What is the consistency in that?
Sir, it will be irregular surface, sir.
Yes. When
Yes,
you're
sir.
already mentioning your surface is smooth,
Yes,
it's
sir.
a firm mass,
Yes.
right? So you're not feeling a different or a variegated consistency or like, bubbly surface or something, irregular surface, you can say.
Yeah,
Yes, sir.
MCDK will not be palpable like a
Ah,
mass.
Yes, sir. Yes, sir. But since it's the second most common palpable mass, and in case of an hydronephrotic MCDK, it can appear smooth to palpation, sir. That is why I have put in the
Very,
second.
very rare, very, very rare.
Yes, sir.
What you tell common things first. I'm
Yes.
asking in a 6 or 8 month old baby antenatally diagnosed renal mass, what else it can be?
Sir, any so first is an first most common palpable is PGO, second is an MCDK, sir. Third is we can
No, because you have written, I will not accept that whatever you have written is correct.
okay, sir.
Because you have
Sir,
written MCDK, shall I accept that MCDK is the second most common diagnosis? What is
sir,
more
no.
common tumor? You are telling me a firm mass
Sir,
by going by a finding.
Sir,
Firm
congenital
mass.
nephroplastic nephroma, congenital Wilms tumor, neuroblastoma.
Why it can't be a neuroblastoma?
Yes, sir. But since child is well preserved and child is having no pallor, I'm going in for it.
See,
oh,
what is
that is the
4S?
only thing. That is the only thing because the child is only 5 months old.
Yes, sir.
Yeah, long life there to become paler later on, right?
Yes, sir.
So that is
What
not
is
the only.
neuroblastoma 4S?
Sir?
What is neuroblastoma stage 4S?
Sir, less than 18 months with less than 18 months, any neuroblastoma with even metastasis to skin, liver, or bone mets less than
When is
10%
it
of
diagnosed? When do you diagnose such cases?
So stage 1 and 2.
No. What
Yes,
stage
sir.
1 and 2?
4S,
Sir,
4S.
antenatally 4S.
Or
Yes, sir.
antenatally, no.
Yes,
So
sir.
early
Antenatally we can diagnose.
antenatally, so you have diagnosed at 5 or 6 months. The child will be well only. There will not be any anemia, or he may not be having failure to thrive. That will
Yes.
happen all in later stage.
Yes, sir.
So don't be very fixed in your ideas that whatever you have written, those are the diagnoses.
Yes, sir.
Okay, if the examiner wants, he can take you totally towards neuroblastoma, and the thing will end up in neuroblastoma without discussing about PUJO. Okay,
sir.
so don't be very dogmatic in your whatever you are suggesting as the diagnosis.
Okay,
Be
sir.
flexible.
Yes, sir.
And one more thing is, like, whenever you are describing, like, a bag filled with a fluid, when you are talking about hydronephrosis, generally it is not a firm mass what you expect. They are cystic masses. So
Okay.
unless you are fixed with your palpatory findings, it will be very difficult for you to prove your diagnosis. So
Okay,
you
sir.
want to say it is a firm also, and then you want to say it is a cystic, you know. So it will be very difficult to justify. At the same time, you should confirm that yes, it is a very tense cystic mass. We have not seen such type of hydronephrosis in 5-month-old child, right? So they are not that tense that you always say it is a cystic. So be careful while you are, this palpatory, based on this only palpation or inspection, palpation and percussion, you can lead the examiners towards your diagnosis. Otherwise, you will, stuck up somewhere. So what is your percussion?
So there is a dull note over the mass and the renal angle dull note is noted. So there is no free fluid.
So, I mean, what do you mean by this? What are the very important percussion findings of a renal mass? If you go back to your general surgery, days,
Yes, sir.
right? So, what are those percussion? What do you mean by doing all this percussion?
Sir, any solid mass or fluid filled mass will appear dull, sir, and the bowel will resonate. So,
So, what is
there
the
will
classical of renal mass then? What is the classical of liver mass? Classical of dullness, or I mean percussion of a splenic mass. How will you differentiate all this based on your percussion findings?
uh, sir, solid will be more.
I would like to say, you forget about renal masses, forget about your diagnosis.
Yes,
But
sir.
for as a appearing in exam, you should be open to all the angles. You
Yes, sir.
cannot be like, I will be only asked about the renal things. No, it should not be like that. So when you are talking about percussion, you should know what are the different percussion findings. How will you differentiate liver mass from the renal mass? How will you differentiate from the kidney mass or a splenic mass to the left-sided renal mass? So what is a very important percussion findings so far renal mass is concerned? What do you call that?
Uh,
You already said bowel is resonant. So what is that important finding?
There will be a band of resonance over the renal right lumbar region, sir, uh, and it will be comparatively very dull to the liver percussion, sir.
Very dull. What do you mean by band of resonance?
Sir, surrounding the renal mass, the renal mass will push the bowels medially, sir. So there will be resonance around
No,
the renal
no,
mass.
no, no, no. So where will be the bowel? Where will be the colon? In case of right side, where will be the colon? So it's a renal mass is a retroperitoneum which is enlarging. So what will be the actual anatomical,
So it will be
picture?
anterior and pushed medially, sir.
So if you, how will you detect this band of resonance? You are rightly said it's a band of resonance which
Yes,
differentiate other swelling.
yes.
So what do you mean by, and how will you examine that?
So from the lateral most we have to percuss and come, sir. And towards medially it becomes resonant, sir.
No. There is a swelling. I would say that there is a swelling and then there is a band over that, right?
Yes.
So you start percussing from medial to lateral. So you
Okay.
first initially will encounter the swelling itself, form swelling. So it will be
Yes.
dull on percussion. And once you
Okay.
come lateral, then there is a band of resistance. Then again there is a dullness. So it's a swelling in front of there is a bowel, right? So
Bowel.
that is a
Okay.
classical of any renal mass.
Okay.
Okay. So that is very important, which you have not mentioned, whether there is a band of resonance is there or not.
Okay, sir.
So if it is a left-sided renal mass and left-sided splenic mass, how will you differentiate then?
So splenic mass will be usually going towards the right iliac fossa, sir. Towards where it is more palpable, we can see that. And the second thing in percussion, so
That is the only thing, or any other very important thing about the splenic mass?
renal mass will be comparatively better.
What is classical of a splenic mass?
Classical of splenic mass.
Sir, it moves towards umbilicus and towards the right iliac fossa, sir.
No, there is something
No,
else.
classical.
It will
See,
clash.
that's what I am telling. Every organ has a
Sir,
classical
it
features.
has a splenic notch on
Yeah,
palpation.
Yes,
Yes, sir.
yes.
splenic notch you should tell.
Yes, sir.
Right. So that way you have to differentiate renal, splenic, and liver mass. Generally, and the retroperitoneum. All these things. When you're talking about the liver, then liver dullness is merging with that. Right? Rest of the
Okay.
abdomen is resonant. Okay, you told about the free fluid. What do you, I mean, how will you detect this? When you say no free fluid means what? How will you detect small amount of fluid? How will you detect moderate? And how will you detect ascites? What are those
Uh,
examinations findings?
Sir, first is if there is a gross fluid is there, then fluid thrill is seen, sir. That is while keeping an hindrance in the middle of the umbilicus and striking from the lateral flank, right flank, can be palpated in the left flank, sir, in case of a completely fluid filled abdomen. In
Can you
case of
alone do it or you need somebody else
You
to
need
somebody else to do it, sir.
what they will do? What the other person will
They
do, what you
so
will
they
do.
will keep the hand in between, sir. In the at the level of umbilicus, they will keep the hand.
So why you want to keep a hand?
So that uh,
I don't want to keep a hand. It's a ascites. We'll tap on this side and feel on that side. Why? Why you want to keep somebody's hand? Why you want to tell somebody that please help me?
uh, so that the the movement of the fluid can be
Yeah, you are wanting to see the movement of fluid only.
fluid
What else
only.
you want to stop? That is why you are keeping the hand in the middle.
Mm.
Where else the thrill can be transmitted?
So fluid can be transmitted
No.
above the
When you are seeing the fluid thrill, you are,
skin. It can conduct, sir. So
what is the skin?
sir,
Below, in the abdomen. In the abdominal wall you are keeping,
yes,
the
sir.
fat in the abdominal wall will transmit that thrill. So
Sir,
to avoid that, you are trying to keep a hand there.
yes, sir.
Okay.
Yes, sir.
Okay. Then what about the moderate fluid?
Sir, shifting dullness we have to elicit, sir.
So how will you elicit that?
Sir, first keeping the from the lateral flank, we have to keep percussing, sir. And when there is a dull note, we have to shift the patient to the in the lateral position, sir. So if I'm palpating from the right side, then just at the level of umbilicus, if I'm getting the dull note, then I will put the patient in the left lateral position and leave it for a minute so that all the fluids gets to the left side. Now again I will start palpating, then it will be resonance, sir. Then again I will start palpating from that area. So there is a shifting of dullness will be there, sir.
Okay, and what is another last one? Small fluid or
It's
a
a
little
puddle
amount?
in,
Yeah.
we can put in the prone knee elbow position and look for the puddle signs.
So what is that?
Sir, we can just focus at the level of above the umbilic in the knee elbow position, in prone, above the umbilicus we can just uh, uh, focus, sir. And
Okay.
that very difficult to do in children, sir.
Right, true. But you should know, right? So you
Yes,
should
sir.
know all these things.
Yes, sir.
And that's fine. We don't do all these things in the children.
Yes, sir.
Ultimately, the fifth arm sonography will guide us, right? So
Yes,
don't
sir.
worry about that. But you should know all the basics about all these signs. That is
Can
very
a
important.
patient of PUJ have free fluid in the abdomen?
Sir, very, very rare, sir. No, sir.
If it is there, what is the reason?
uh, Sir, if child is well thriving and it's not in case of, there are two chances, sir. In case if child is going in for a CRF, that is a renal failure, there can be an ascites. Or if it is a very huge mass which is causing, in case of any PUV, then it can cause an perinephric urinoma, sir.
No, even a mild trivial trauma sometimes can lead to rupture of the
Rupture.
PUJ and it
Yes, sir.
can lead
Rupture of
to
the pelvis.
urinary ascites.
Yes, sir.
Okay, carry on.
Mm. So these are my differential diagnosis, sir. Sir, so going on to investigations which child have, these are the antenatal scans, sir, which mother has. So the antenatal scan first done at 21 week, showing a mild right renal pelviectasis of APD 11 mm with AFI is 10 centimeter. There is no mention about the parenchymal thickness or the ureter or the bladder, sir. So we take it as an right HN of 11 mm at 21 weeks, which is coming for UTD classification A2 with AFI 10 centimeter, which is normal, sir. And at 36 weeks, there is a severe right pelvic LCL dilatation, and APD is 27.3 mm with severe parenchymal thinning. They are not mentioned about the parenchymal thickness and not about the ureter or the bladder. So we take it as an a right HN with severe parenchymal thinning. It is coming to A2, UTD A2, sir. And AFI is normal, 12 centimeter. And the left kidney is normal, they have mentioned. And size of the kidney is also.
So, I mean, only two antenatal scan at 21 week and then straight away 36 week? Or they
So
are
they,
advised and patient doesn't turn up?
the patient does not have, so they have only these two scans.
Okay, okay.
So what will you counsel the parents with this scan if they come to you antenatally?
Sir, they are coming under the UTD A2, sir. So I have to do an postnatal scan
No,
after
no,
1 week.
you tell, counseling part you tell. What you will
The
do later
counseling.
on is okay.
Okay,
What will
sir.
you counsel the parents?
So, so this child is having a right hydronephrosis. We have to do an ultrasound post natally after 1 week, and then we have to follow up the child. Child may need surgery after doing an scan at after 1 month of age, sir.
So
And
is it a better way to say that don't worry, it's a unilateral hydronephrosis.
yes,
Another
sir.
kidney seems normal. We'll keep watch on the fetus. You are not telling that we'll straight away. You are talking about 21st week. You cannot say once there is a birth postnatal we will do that. But before
Yes,
that you have to make sure that family doesn't, they are not worried about these things. So you can say it's a unilateral. Most of the time it is detected early, so we'll keep watch, we'll keep follow up. If
sir.
this AFI is 10 centimeter at 21 weeks, if it remains same, then there is nothing to worry about, but we will keep watch on dilatation and AFI, right?
Yes, sir. Yes, sir.
So don't worry, you are not forced to undergo any cesarean section or any emergency things, but yes, please keep yourself in contact with your gynec or continue with the regular follow-up, and you can come down to see me around maybe 28 30 weeks again. We'll look
Yes.
about whether they come or doesn't come. That doesn't matter. But we have to tell them that this is the prognostic level. Like this is the way we are going to follow. This will end up like this as a delivery, and then what you are supposed or you are advising about the postnatal management. So it is a
Yes.
unilateral. Based on that, you have to advise postnatal things. So
Yes.
not from 21st week to postnatal, but it's a whole course you have to explain.
Yes. Sir. Okay, sir. Sir, since the left kidney is normal and we no need to panic. I've asked them we have to follow up with the ultrasound and then postnatal also we have to follow up for a regular follow. That
And
much I
you
have.
have to tell them there are chances it may become normal on its own.
Yes, sir.
If you tell surgery from the beginning, they will abort the fetus at 21 weeks somewhere else.
Yes, sir.
Okay, you always should give them hope. If you
Okay.
tell that this baby we have to go and operate after the delivery, we'll do the scan. If that shows increase in size, we'll straight away do surgery. They will go to some other center about the fetus. Okay, so give them some hope that there are chances it may become all right. We have to observe for some time. Only if it is increasing, we'll think what to do.
The spontaneous regression.
So if you say at 21 week that yes, this child may need postnatal surgery, they will straight away go to gynec and then they will never turn up. So you
Yes,
have to
sir.
be very careful and you have to make sure that they believe your statements, they trust you and they come back to you frequently. That is the only way to keep the same patient in a postnatal time, right?
Yes,
So
yes.
like you have to have a bond with the family, like the way you explain, they should trust you like, okay, this doctor is perfect,
Yes, sir.
right?
So how are you going to follow it up?
So now the child came to us in 6 months only, sir. So first we have to do an ultrasound in the OPD basis, sir. To look for the first ultrasound postnatally. So this is the ultrasound done postnatally at 6 months of age, sir. So right kidney is 8.4 centimeter, which is increased for the age, and the APD is 3.5 centimeter. Parenchymal thinning is present 2.7 mm. A corticomedullary differentiation is maintained, and echoes is normal. Left kidney is 5 centimeter, which is normal for the age, and there's no compensatory hypertrophy. And left kidney is absolutely normal. Bilateral ureters is not visualized, and urinary bladder is normal with no bladder thickness is normal, sir. This is the ultrasonogram, which is showing severe parenchymal thinning. So,
This is at what age?
this is at 6 months of age, sir.
So what is your cutoff for APD, where you will tell that, okay, this is grossly abnormal or this is normal or this is borderline?
So basically, we take parenchymal thickness first, sir. So parenchymal thinning is present, then first, and the APD, in case of an APD, so 2 centimeter is the cutoff we usually ask for a scan, sir, and 15 mm is where we follow up, so we start following up.
So one thing I would like to tell, this is at the 6 month, right?
Yes, sir.
So what about immediate postnatal ultrasound?
Sir, they haven't done, sir. They
They
haven't
haven't
done.
done. Okay.
Yes, sir.
And actually, if they want to do, when you will advise actually in antenatal period that you please come back once, there is a birth. So what is that time?
So after 7 days, after 1 week, I asked them to come, sir, to avoid the postnatal diuresis, because the postnatal diuresis will cause an false negative.
Are you sure it is 7 days or it is something less?
So 5 to 7 days.
Okay. Please check it. I think it is after 72 hours.
Okay, sir.
Just please check it. I actually, yes, but you have to be very sure that when you are bringing patient back for ultrasound, and based on that, your next follow-up will be. But yeah, this is many times it's a routine scenario. When patient is coming from the periphery, they will come straight away at 5 or 6 months whenever they find that, okay, now let's check what is happening with the kidney. So if this is the finding, what is your next advice?
Sir, our institutional protocol is to, we usually do an IVU for initially, sir. when the child is coming with the parenchymal thinning, I would like to admit the child for an IV user. I will do bowel preparation. I will do an RFT to look for the creat. I will check the BP. Then I will proceed with an IV user. This is our institution protocol, sir. Since we are sir, the EC renogram and DTP is not available at the center, and we have to send it to other center. And if they are not affordable, for the ease of we are doing IVs.
Okay, renal scan is not available around, right?
Yes, sir. Yes, sir. Well, so only in cases, in selected cases, we'll do EC renogram, not for all the patients, since it's
Why?
not
Why?
available.
If it is
Sir,
available, no,
sir, it
in
needs
those selected
PMC.
cases where you are sending those patients,
Sir?
in those selected patients where you are sending.
So we are sending to other institution, other labs outside private labs when they are affordable, or under CMCHS scan, we do so, only for selected patients.
So if it is available in the city, right? It's
Sir?
available in a private setup,
Yes, sir.
but not in the institution.
Sir, in a government, we are in a government institution, sir. So
No, we are also in the government institution and no renal scan. I mean, not available in my setup. But do you think that is a justification for going for IVU?
uh, sir, since the time to get CMCHS the card for them is very difficult, sir, and it takes around affordability also. We have to see the patient, sir. So based on the concern only, we are doing first initially IVU, sir. This is if the anatomy is clear and there is a good function in the IVU only, then we will proceed with the pyeloplasty directly, sir. Only if the function is poor at the 5 minutes and the excretion is poor, and we are not able to pick up the renal function, or if it is a bilateral PUJO, then only we will go for an EC scan, sir. We are advised the patient to take EC scan, so that is the institutional protocol being followed at our institutes.
So what about
But
MCU
do you
then?
think that is acceptable?
Sir,
It's an
we know
institutional
that it's
protocol,
IVU.
but how reliable is the IVU to tell you whether the kidney is functioning or not? How can you
Sir,
know if the kidney is functioning? If there is
sir,
no contrast seen, does it mean that the kidney is not functioning?
sir, no.
IVU is not at all reliable
I
method
mean,
for
yes,
knowing how much is the function.
it's
How
a,
will you know
it's,
the percentage of function?
yeah, the guidelines doesn't support this statement, right?
Yes, sir. Yes, sir.
So in exams, I mean, you are right. Many times you can say that it is our institutional protocol, but we should find out some ways, like what we have done. We have done some MOUs with the private institution, that all
Yes.
for all those PMJ patients and all those school age patients, we are sending them and then we can reimburse them, right? So
Okay.
we can develop some protocol, because it is a guidelines. We cannot just go away with that. At the same time, you are not sure what you are dealing with, because ultimately you have to explain the parents also that yes, this is the function and this will be the post operative, the way we are following it up, and whether it is improving or decreasing, you don't have any idea or any answer for that. But
Yes.
before that, moving, I would like to ask whether you will go for MCU or not.
Sir, MCU we regularly do if the ureter is seen, or any case of UTI is present, any history of UTI is present, or in case of an bilateral HN, or in case of an single kidney status, we will do an MCU, sir. Otherwise, we will not do an MCU.
Okay, if so, if there is no urinary tract infection, or if there is no ureter dilatation seen on ultrasound, I mean, ultrasound is a operator dependent investigation.
Yes.
A good sonologist will find out the dilatation, the routine one, maybe done by resident, done by second year, done by rotators, done by how do you think you can rely based on that only, that ureters are not dilated? Have you ever experienced that ureters are not dilated, and when you are planning for PUJ, you open it and then you see, oh, ureter is tortuous and dilated? Have you ever?
Yes, sir.
Yeah, I mean,
Yes, sir.
so it's again an operator dependent, findings, that it is very difficult to, particularly for a very younger child, 3 months, 4 months, 5 months, they
Yes,
may
sir.
not, or they are, that depends on their own expertise. I cannot say they cannot detect. They can definitely detect. So there
Yes, sir.
could be some indirect findings also on ultrasound. But what do you think? MCU should be done or not? Because ultimately you have to rule out with the other differential
You are, sir.
diagnosis for whatever you say hydronephrosis.
Yes, sir. Sir, so since sir, it's an invasive test, so only in case if a child is having an UTI or
Parents are very highly educated. They are taking care. They know the there is antenatally detected some renal issues, though they come down at 6 months, but they know there is some problem. If they are taking care, there is no urinary tract infection. In fact, urinary tract infection presented with fever is treated by pediatrician with antibiotic considering upper respiratory tract infection, which is commonly done.
yes, sir.
So unless you have all those findings having no UTI of urinary examination, it's a dictum. Whenever there is a fever, you should do urinary examination also, right?
So then we can
Not
do an
only
MCU.
CBC and all this dengue, fengi, everybody is doing. But
Yes, sir.
so all these things are, subjective. It is very difficult to justify based on
Yes.
that. I
Yes.
think Prakash sir may tell something, yes, based on that.
Yeah, I agree, sir, because only if you rely on the ultrasound, it is not correct. Sometimes you may miss out a viewer, and on
Yes, sir.
table you will land up in a surprise. So little bit of doubt, better to do a MCU and rule out a reflux in the
Yes,
case
sir.
of PUJ.
Yes, sir.
So what next?
So I have IVU and DC renogram films, sir. First, I'll go with the IVU film, sir. This is scout film. The spine is normal. There is no abnormal radio opaque shadow, and there is normal bowel gas pattern. It's a 5 minutes film where we can see right side crescent sign is seen, and left side there is a prompt uptake and excretion in the pelvis. And we can also see the bladder is filled in the 5 minutes. In 15 minutes also the contrast opacification on the right side is seen more. 30 minutes also the contrast opacification is increasing on the right side. In 1 hour we can see the left kidney is draining, and we can see the ureter on the left side as well. Right side the ureter is not seen and the contrast opacification is increasing. And in 3 hours we can see the pelvis is filling up with the contrast, and it's up to the midline it is coming. And by 6 hours the left kidney contrast has almost drained, and right kidney there's a hold up of the contrast with the dilated pelvis. Sir, with this we can say that there's no ureter also seen on the right side. We can confirm that this is this can be an right pelvic junction obstruction, sir, with the dilated.
Do you think it is very difficult to find out ureter? If you compare the left-sided ureter,
Yes, sir.
can you go back to the slide?
Yes, sir. This is
Right? You can just see the pelvic portion of the ureter. It's such a small thin line surrounded by lots of bowel loops.
yes, sir.
And the same thing you are trying to find out on the right side. It is, again, the reporting of the such type of films are again subjective, very difficult. So,
Yes, sir.
that is a one more reason that, yes, anyway, next.
So since the function is very, the uptake and the excretion is very limited in 5 and 15 minutes, sir, we went ahead with an AC
So
renogram.
you took picture of at 6 hours. You go back to one more slide. Yeah,
Yes,
it's
sir.
so you always take this many pictures.
Yes, sir. We usually take so 6 up to 6 hours with 1 hour film we will take, sir.
So every 1 hour, so like 5 or
Then
6
like
exposures.
30 minutes, 1 hour. 30 minutes is a prone film. 1 hour, then a 3-hour film, then a 6-hour film.
So 4 or 5 exposures, and
5
then
exposures,
after
sir.
6 hours, this is the finding. Then you will stop it, right?
Yes, sir. We will stop it.
So actually, what you are, what is your aim to do all these multiple films? What do you want to actually highlight? Whether it is draining or whether ureter is visible. What are your?
So the ureter visibility is checked at the 1 hour, 3-hour films. And also the anatomy, to get the anatomy, it is getting filled up only in the 1 hour and 3-hour films. That is another.
That is what?
Yes, sir.
No, that is what? What do you mean by that? It is filled up in a 1 hour or 3 hour or 6 hour.
Like,
How will you differentiate? I mean, what is your thought about that?
sir, it has a the excretion is sir very delayed in the right kidney, sir. That is what we can.
Yeah, that's visible in the first or 2 or 3 hours film also.
Yes, sir.
You go back to 1 3 hour film.
Sir,
1
1
hour.
hour film.
Yeah, then
3 hour films.
yeah, that's 3 hours. You can see very nice pelvis and
Yes, sir.
okay. Oh, that's fine. Next. So you have done scan also.
Yes, sir.
Why it
Sir,
was done in this patient?
sir, in this patient, since the 15 minutes only crescent sign is seen, sir. And then we have to document the functions. If the clear-cut anatomy is seen in 5 minutes and 15 minutes, the complete pelvis and is seen, then we will say that go ahead with an pyeloplasty, sir. Since the function is poor, we have to document the function prior to surgery, sir.
So
But
what
if you
was
have an
function?
option of DTPA and IVU, what will you do?
Sir?
If you have both the options, will you do a IVP followed by a
Or
DTPA,
if
or you
both is
will
given,
just
then
do
I
a
will
DTPA?
go with an EC renogram. So
Huh?
if both is there, then I will prefer EC renogram to IVU, sir, since IVU is always having the contrast-induced nephropathy and the radiation exposure chances is
Yeah,
more.
so much of radiation is for 6-month-old,
Yes,
then
sir.
followed by a DTPA. Why not do a DTPA right away?
That's what I'm asking. You have done both.
Sir, this only after the function is poor, then only we'll proceed. This is actually this is an institutional protocol, so that is why we have done both. Otherwise, we can straight away go with the ECD.
But how do you know the function is poor?
Sir, in the 5 minutes and 15 minutes, the extraction is not prompt and when compared to the left kidney, sir.
That is okay, but the function may be little bit less compared to the
Yes,
left
less
kidney.
compared to the left kidney.
Both
And
the kidneys will never have the same function. No, it will be little bit up and down.
yes, sir.
But in the 3 hours film, nice contrast is seen.
Yes,
That
sir.
means the kidney is functioning only.
Yes, sir, it's functioning,
Yeah.
sir. But since it's not showing up in the 5 and 15 minutes, up to 1 hour, there is only a vague pelvis filling only is seen, sir.
Because it's a hydronephrotic kidney, it will always be diluted.
Yes,
The
sir.
contrast will be diluted, it will not be seen as compared to the left kidney. That also we
Yes.
have to keep in mind. Even though the function is little bit lesser than the left kidney,
Yes,
it's
sir.
the hydronephrotic kidney. The contrast will always be diluted
Yes,
compared to the left kidney. So you cannot expect the same amount of contrast as you see in the left kidney.
Yes, sir.
Understand?
Yes, sir.
So what's the finding in this scan? What does it says?
So this is a perfusion images which is taken at 4 seconds per frame, sir. So in this, the left kidney is seen at the third film, and only at the fifth film we can see the right contrast radio tracer uptake in the right kidney, and we can still see there is a pelvis is not filling up even in the last film of the perfusion images in the right kidney, and there is a poor perfusion of the radio tracer in the right kidney, where the left kidney is nicely contrast uptake is present, sir. This is an excretory phase where we can see, this is an excretory phase where we can see the left is a prompt excretion is seen, and we can see the pelvis is filling at second film. This is taken at 1 minute per frame, and we can also see the bladder in the third film. Even up to the fourth film, the pelvis is not getting filled in the right, and only after the fifth film, we can see the pelvis is getting filled, sir. And there's no ureter seen. And even in the in the last film, we can see the left kidney is completely drained, but the right kidney, there is an increased radio tracer hold up in the right kidney at the last frame. So this is the perfusion curve. This the white is the aortic curve, and this is the left kidney. Right is the left kidney, and the green is the right kidney. So the perfusion on comparing to the aorta is reduced compared to the left kidney and also compared to the aorta. And this is an coefficient time activity curve where we can see the left kidney have a smooth up slope and down slope, and right kidney having an Tmax attained at the level of 14, sir, and it's not raining only, it's a continuous upsloping curve and it's not raining. So we can see the Tmax of the right kidney is around 14 and it's not raining only. T half cannot be said, and the split renal function of the right kidney is 35% and left kidney is 64%. This is the pre-wide image, and this
35.
is 35.9.
Okay, it's a 36. Okay.
Yes, sir. And this post-wide images, we can see still the hold up of contrast is a renal tracer. Tracer is seen in the right kidney, and even the delayed 2 hours image, also there is a radio tracer hold up is seen in the right kidney, sir. While the left kidney has completely drained in the pre-wide and the post-wide images, also it's drained, sir. So with the report that they have given us shows moderately impaired coefficient with parenchymal radiotracer uptake in the prolonged in the intrarenal cortical transit. With the right kidney of split function is 36% and left kidney is 64%. So.
Okay, so with this report, what is your next plan?
So with this report, since the kidney function is already decreasing, we should proceed with an pyeloplasty.
Straight away.
Cut off, like if the same patient come at 1 month or 3 months or and having a function of 45 or 48 and then 40 and then 38 and or the something like this, then they just present at 6 months and the function is at 36. So what's your call? Like if there is a function of 45, what will you do? If it is a 40, what will you do? If it's 36, what will you do?
If there is so the indication for pyeloplasty or decreased parenchymal thinning, or more than 10% difference between both the units, or there is less than 35% function in a single unit, these are indications for the pyeloplasty, sir.
So
And
the first two are very important when you are follow-upping the patient. Somebody
yes,
is presented at 45% or 48% or 43%. Pelvic
yes,
diameter and parenchymal thickness, you can follow up it up. But once it
yes,
is comes straight away down 40, I
yes,
think
sir.
you can definitely advise her. 35 is one of the important cutoff that you go ahead straight away to the pyeloplasty.
Pyeloplasty.
Okay.
Is there an indication of pyeloplasty right from beginning?
So parenchymal thinning is present even at the antenatal cancer. So
No,
this should
depending on
this,
your clinical finding.
so the palpable mass, sir.
Yes.
Yes.
Any
Yes.
palpable
Then
mass at the
single
newborn kidney,
kidney?
sir.
Single kidney?
Single kidney also, sir.
Yes. Right.
Okay, do you do a stentless pyeloplasty or with stent?
So we will do a stent, with stent only we will do a pyeloplasty, sir. Double J
What
stent we will do.
pyeloplasty? Laparoscopy open.
So we routinely do open modified Anderson-Hines dismembered pyeloplasty. Only in so we routinely do open, but in older children we are doing lap pyeloplasty as well. Older children in the sense more than 3 years, we are doing lap pyeloplasties.
What can be the cause of PUJ obstruction in an older child, 7-year, 8-year, 10-year-old?
Sir, lower polar crossing vessel can be a problem, or an retrocable ureter can be a problem in the older child.
So what is your protocol for stent, and when do you remove? Do you keep a drain?
Sir, Sir, initially we do a DJ stent and we will put the child on chemo prophylaxis with syrup Septron at 2 mg per kg in the night dose. And after 6 weeks, we will again ask the child to come. We'll do an ultrasound and check the position, and then cystoscopy guided removal or cystoscopy guided removal is the routine removal. So that is a post-op. We'll manage the stents. And regarding drain, we glove drain is kept for the first 2 days. Then we will remove.
So after the surgery, when do you remove the catheter? When do you remove the drain? When do you remove the stent?
Sir, catheter we routinely don't put in the children, sir.
Don't put.
Yes,
Very
sir.
good.
So, I mean, you are keeping catheter, sorry, you are keeping drain as well as stent, both?
Sir, perinephric draw drain is kept initially, sir, and some people,
Even if you keep a stent.
yes, sir. Yes.
Uh-huh. Okay. If stent doesn't pass through the view junction, what will you do?
So first thing, we can flush it with an 4 French or 3 French IFT, sir. Then or else we can put a guide wire through the stent and try negotiating but with the risk of ureteric injury, we should be very careful, sir. Then we can do a tube, a nephro stent if available can be, sir, or tube nephrostomy or cystoscopy, and retrograde we can put the DJ stent into the pelvis, sir. Or we can do a tube nephrostomy.
It is very difficult and cumbersome to do cystoscopy on
Yes, sir.
table and then.
Yes.
But yes, what do you mean by nephro stent?
So nephro stent is there is only one loop, sir, which just across the pelvic anastomosis, and the other end of the stent is percutaneous. We can remove it. It does not need a long 6 weeks and does not need another anesthesia. We can remove it percutaneously.
Right. So it's a not nephrostomy, but it's a nephrostent passing
Yes.
through the anastomosis. And your
Yes.
purpose of keeping all the stents or anything trans-anastomotic is just to prevent the stricture and adhesion there, right?
Yes, sir.
So yes, you can keep a nephrostent, or you can just take a like stentless surgery. Don't keep
Yes.
anything, keep a drain and then just watch it, observe it. What will you do if there is a urinary leak post-operatively?
So if there is urinary leak, first we'll catheterize the child and put the child on a higher antibiotics. So then if child is having fever or raised counts, then if the stent is present,
No. There is no stent.
okay, sir. If there is no stent, then we will, and if it, when, so usually we see urinary leak in lab cases, sir. So usually they will be having a tube drain. We will quantify the drain, sir. If it is more, if it is more like so more than 200 ml, then we will go and check for an ultrasound if there is perinephric collection or pelvis is dilated. If the pelvis is dilated, we first do an pigtail of the nephrostomy with the nephrostomy tubes with the pigtails. So that way we'll drain the urine, and once the anastomosis is completely healed, then we will do a nephrostogram to check the patency of the PUJ anastomosis. And then if it's completely healed, then we will remove the pigtail as well.
One thing, please explain. You don't keep a catheter, right? Not on table, not post-operative.
Yes,
You are
sir.
not keeping catheter. What's
Yes,
the concept behind that? Actually, you should keep the catheter or you should not. And if you
Sir,
want to keep the catheter, yeah.
Sir, during surgery, we will check for the position of the DJ stent by placing the bladder intraoperatively, sir. So whether the urine comes out through the pelvis. If it is inside the bladder, it should come out. You should have the jet of urine coming after placing the DJ. So to check that, we won't keep a catheter. And child or the infant, they are not. They don't void at controls, so no need of keeping an catheter for infants. An older child, some people may keep a catheter. but we routinely don't do a catheterization.
But
Okay.
that to see
Generally,
the
it helps,
stent
you
in
know.
the,
Yeah.
to see the urine coming out when you are putting a stent, you
We
can
can
put the
always
catheter and clamp it.
and
That
then
is
clamp,
that.
sir. Yes, sir.
Yeah.
In case of an in lab cases, we will usually put a catheter and clamp, sir.
So this is a routine practice. You keep a catheter,
Yes.
clamp it, because that will help to identify whether the lower end of stent is there inside the bladder, right?
Lab.
So
Yes,
once
sir.
everything is done, you open it, keep it for a 1 or 2 days, so the bladder will drain smoothly urine. So this will help for all these things, because you have all handles the lower ureter, this and that, view junction. I
Yes, sir.
mean, yes. So that's the reason you keep bladder empty. So that helps. But otherwise, also it is removed after 48 hours, right?
Yes, sir.
So that's true. Okay. So lap is not done at your place.
The lab we do, sir, more than for infants we are not doing, sir. Otherwise, we are doing lab pyeloplasty.
Okay. Okay. Inferts or not. So it is a right or left, any preference, or it is extravesical or a retroperitoneal?
Sir,
I mean, sorry, not exact intraperitoneal or a retroperitoneal.
intraperitoneal, sir. Intraperitoneal, mesocolic approach for left side and retrocolic approach for right side, sir.
Okay. Okay. All right.
Okay.
So, I mean, what's your post-operative follow-up of all these patients operated for pyeloplasty?
As I already told, the degestant follow-up is for after 6 weeks. We will ask the child to come and cystoscopy guided degestant removal, and we will stop the chemoprophylaxis then only, sir. Then after every 3 months, we will ask the child to come for an ultrasound, or if any UTI, will inform the symptoms on signs of the UTI, sir. Then every 3 months, we will check for any rise in the anteroposterior diameter or any parenchymal thinning. Then after 1 year, exactly after 1 year, then we will either do an EC scan, repeat an EC scan, or DTPA, or if that is prolonged, then we will do an IVU only, sir. Sometimes if they are not affordable, check IVU only, sir. So if it is draining at 6 hours, or ureter is seen on the right, on the operated side during the IVU, then we will follow up only for 2 years, sir, with
So,
3 months.
so if there is a dilatation at 6 months of age, you see the hydronephrosis.
Yes, sir. Sometimes the residual pelvic dilatation will be present, sir, but we should only look for parenchymal thinning post surgery, sir. Parenchymal thinning is more important rather than the APD, sir. But if APD is increasing grossly, like compared to the pre-op size, then we should have a close follow-up and do an EC renogram again, sir.
So what's the institutional protocol so far? The large pelvis is considered. It's a wide dependent drainage or a reduction pyeloplasty.
Sir, reduction pyeloplasty we do, sir. We do an modified Anderson-Hines dismembered, 1 to 1.5 centimeter wide, vascular, watertight, funnel-shaped, dependent drainage.
Okay, that's great. I think it's okay from my side, sir.
Shall we call it off, sir? I think she's answered well.
Yes, sir. Yes, sir. Yeah, that's great. So the only
Anything
thing
else
I
you
would
want?
say that just think about the abdominal mass,
Yeah.
different sites of origin, and then their particular findings. That will helps a lot. And try to make it's a summarize your case. When you are told to summarize your palpatory finding, it should be in a single sentence, right? All the findings should come in single line. I think if you keep that habit, because you are going to get examination, that is for sure. Either it is cystic or a solid, but there are different lumps: retroperitoneum, liver, spleen, and kidney. These are the basic things. So just keep yourself ready with all this plus minus. Then only you can rule out other systems. So I think that way you have to go ahead and don't fix up your mind with one diagnosis. Keep yourself open, whatever they ask. Examiner knows that you are thinking of pyeloplasty or you are thinking of hydronephrosis. They will take you to neuroblastoma. So you should learn how to lead the examiners. by telling something which, always prompt that, okay, if she's telling this, let me ask this. So yeah, that way you can lead your examiner. Uh, I think that's sir.
Yes, sir. I completely agree.
Yes, sir.
So have an open mind in exam. Don't go by the one single diagnosis. Don't get biased. Whatever you see, whatever you feel, you present. Even if you are able to justify a wrong finding, that is accepted.
True.
But if you are caught that you know the case and in everything you are telling one-sided biased, then the examiner also will be little bit biased. Okay. So go with open mind. You did well. Everything you did fine. You know
Yes.
the subject, but have your findings proper. And when you are asked to demonstrate, you should know how to do it, how to demonstrate it. Okay.
Yes, sir. Okay,
Good.
sir. Thank you, sir.
Thank you, sir, for
Thank you.
all your time and effort in guiding us today. Uh, Sir, I've forwarded a Google form which will act as the mark sheet.
Yeah.
So whenever you have the time, if you could just fill that in so that we can come to a point of self-assessment so that we can improve
Uh,
ourselves.
I'll fill it right now. Right?
Thank you.
Okay.
Thank you,
We'll
sir.
do it.
Thank you.
Okay. Thank you.
Thank
Okay.
you. Thank you,
Bye.
sir.
Good
Thank you
night.
so much, sir. Good night, sir. Thank you.
Bye. Good night. Good night.